lung inflation, which for any of you who know ARIEL, this is right up her alley in terms of interests. ARIEL, in terms of background, she did her undergraduate at University of Massachusetts at Lowell and did her degree in exercise physiology. She then went on to medical school at University of New England. We had the pleasure of having her here quite a bit as a medical student as well. And now she is finishing up her 4th year of her Med-Peds residency and will be going on to do a pulmonary critical care fellowship at UMass. So in terms of some of ARIEL's interests, she has a strong interest in bedside ultrasound, particularly as it relates to ARDS and related to procedures in the ICU setting. She has also done some research related to pulmonary embolus and how we use biomarkers in terms of our initial evaluation, as well as working on some other work on the adult ICU side related to opioid prescribing practices, both during and post ICU setting. So I look forward to hearing ARIEL's presentation, as I know all of you do today as well. Thanks, ARIEL.
Thanks, Katie. So I am ARIEL McKENNA, a 4th year Med-Peds resident, and I'm going to talk about pediatric acute respiratory distress syndrome and lung inflation. I'm going to move this. I have no conflicts of interest. My objectives for today's talk are lung mechanics and the differences between adults and children, the pathophysiology, diagnosis, and ventilator management of ARDS, ventilator-induced lung injury, point of care lung ultrasound, and lung ultrasound in ARDS patients. This is obviously a pretty specialized talk, and I don't expect everyone to want or plan to titrate ventilators, but the goals are really to just understand the lung mechanics and how ARDS affects them, recognizing ARDS and who's at risk of them, and recognizing the use of ultrasound. So first, we go back to the basics and look at some lung mechanics. Remember this chart from medical school. So here we're looking at lung volumes, and this is normal respiration, and this is forced inspiration, expiration, and then normal respiration. And so tidal volume here is the normal breathing during inspiration. And then we have inspiratory reserve volume, which is the largest volume after a inspiration, and then expiratory reserve volume after an expiration. And then residual volume is the amount of volume in the lungs after a maximal exhalation. And then functional residual capacity, which will be important later, is the volume left in the lungs after passive exhalation. And total lung capacity is the total volume after a maximal inflammation. And here we're looking at the pressures. So we have our trans-airway pressure, which is the difference between the opening airway and the pressure in the alveoli, and that dictates the flow that's able to get into the alveoli. The transpulmonary pressure is the difference between the alveolar pressure, alveolar pressure and the body surface pressure, and that allows the opening of the lungs against the chest wall. And then the pressure across the chest is the difference between the body surface pressure and the pleural pressure. So this graph is looking at the pressure over time on a ventilator. And these are the pressures that the patient is receiving and can be measured. So first we have this peak pressure, and this is the maximal pressure at the end of inspiration. It's measured at the end of the airways. And this is dependent on airway resistance here. And then we have our plateau pressure, and that is the equilibrium pressure after in the alveoli. The peak pressure is equal to the resistance times the flow plus the plateau pressure. So if there is a change in resistance or flow, such as by mucus plug or bronchospasm, that will affect the peak pressure, but won't affect the plateau pressure. But if the plateau pressure is changed, that will affect the peak pressure. And then down here we have our PEEP, or positive end expiratory pressure. And this is the pressure that's left in the alveoli at the end of expiration. And this is a measure that we can increase or decrease to help with oxygenation. And if we remember back to physics or Henry's law, when you increase the pressure in a system, you increase the solubility of the gas. So if we're increasing the pressure, we're increasing the solubility of oxygen, so it can cross the alveolar capillary membrane and then have higher oxygen in the blood. And then next, there's our volume pressure loops. As we change our pressure, we are able to get a certain volume. And on the ventilator, you can set a specific pressure and that will stay constant, but the volume may change with each breath. Or you can do it the other way and set a specific target volume, and then the pressure will change with each breath. And here's this slope is showing the compliance, which is the change in volume for pressure. And that's basically telling us the distensibility, or how the ease with which the lung units will open. And this again is looking at a volume pressure like compliance curve, and we see the alveoli up here. And what this is showing is that you need more pressure to actually open up the alveoli. But if you don't have enough pressure, you have this unopened, derecruited alveoli if you're below this lower inflection point. But you do get to a point if you're above this upper inflection point where you have too much pressure and you're probably over distending the alveoli. And this is basically showing the same thing. Up here, you have this beaking, which is over distension of the alveoli, which is worsening the compliance. And then down at the bottom, again, you have collapse of your alveoli. So again, bad compliance. But then in this middle is a safe zone where you have your ideal compliance. And this is where your ideal functional residual capacity is as well. So as a Med-Peds resident, I always like to think about the differences between adults and children, helps me remember things between them. So here is just a chart looking at the differences in some of the anatomy and physiology. So first, in children, the airway cartilage is incomplete. The airway resistance, there's a greater increase with the reduction in the radius of the airway. The chest wall compliance is greater in children because of the incomplete rib ossification. And in children, there are 20 to 300 million alveoli, and that changes with age. And we also have a lower FRC, or the functional residual capacity that I was talking about before. For respiratory muscle reserve, children, their muscles aren't all developed fully and used, so they do rely more on the diaphragm than adults would. And then the risk for pulmonary vascular remodeling is greater in children, and the metabolic requirements in children are higher. And obviously the lung volumes are different between children and adults. And then there is more elastin in children, and when we're infants, that increases 20-fold in the first month of life, whereas the collagen increases linearly. And so it's different in the adults versus the children. So now to kind of switch over and talk specifically about acute respiratory distress syndrome, which I am very interested in. It's the incidence in the PICU is pretty low. It's about 1 to 10%, but the mortality is high. About 30% of patients who die in the PICU had acute respiratory distress syndrome. So to talk about the pathophysiology first, it's a disorder of oxygenation secondary to diffuse alveolar damage. You can have direct damage to the endothelium, or from indirect damage from inflammation. And when you get disruption of that barrier, you get leakage of fluid, and then also get inactivation of surfactant, and basically your alveoli all collapse. So you can see here, we have all these inflammatory cells. We have all this fluid and breakage of the barriers that's getting into here, and it's disrupting the diffusion, and then they'll also get collapse. An important thing about ARDS is that the damage is heterogeneous. It's not the same throughout the lungs, which will be important when we talk about management. And with all of this going on, you get VQ mismatch, shunting, dead space, you get reduced functional residual capacity as well. There are many causes of ARDS, can be from It could also be from an extrapulmonary process. So a lot of our patients from across the different specialties can get it. So you can see it after pneumonia or aspiration, inhalational injuries, sepsis, pancreatitis, Strawley, or trauma and burns and drowning. So the diagnosis, a little history, we pediatrics used to follow the diagnosis in adults, and we first had this American European Consensus Conference definition that was in 1994. And then next we had this Berlin definition that had some changes, but still didn't really address pediatric acute respiratory distress syndrome. What this one did change was that in the prior definition, we were specific about wedge pressures, but now that we're not really using PA catheters as much, that's not really part of it. And also it used to separate acute lung injury from ARDS, and now the acute lung injury is just off the chart. So then finally, a group got together, the PALIC group, that created this definition for pediatric acute respiratory distress and gave recommendations on management and ideas for research topics in the future. So this is different from our adult definition in ways where, specifically in the chest imaging, in adults you have to have bilateral infiltrates. In pediatrics you can just have a new infiltrate, and so it can be unilateral. Also, they take into account children who have history of cyanotic heart disease, lung disease, or LV dysfunction for some reason or other. And it basically says, these patients can still have ARDS if their presentation isn't due to their underlying problem. And also the way we define pediatric ARDS and look at the severity is based on oxygenation index or oxygenation saturation index, whereas in adults we look more at the PaO2 to FiO2 ratio. And this OI and OSI takes into account the mean airway pressure. So we're actually seeing not just how much FiO2 they're getting, but also the pressure. So it can tell us a little bit more about the compliance and how severe their disease actually is. So the management obviously is to treat the underlying cause. We want to provide adequate oxygenation, ventilation, and then we want to protect the lungs from ventilator-induced lung injury. And as in a lot of topics in pediatrics, most of the data is in adults. So the management of ARDS is a big topic in itself. And so for this talk, I'm just going to focus more on the ventilator strategies. So first, for tidal volume and plateau pressure, there's this big study in the adult world, the ARDSNet study, that's looking at lower tidal volumes compared to higher tidal volumes and found reduced mortality and reduced ventilator days. So we thought that this would carry through with children too. There aren't any randomized control trials in kids. There are some retrospective and prospective studies, and the evidence is kind of all over them. There's some relation to mortality in some studies, and there isn't in others, and there's some that actually shows there's higher mortality with the lower tidal volume. So the general consensus is kind of out, and the PALIC group basically recommends doing normal to lower tidal volumes, which is about 5 to 8 milliliters per kilogram for predicted body weight. And then they throw in this caveat that for sicker patients, you could do lower. If their compliance is worse, then you could go down to 3 to 6. And then patients whose compliance is preserved, you could do the higher end. But what the pediatric studies do compare with the adults is the pressures, and that there is a linear increase in mortality with the elevated peak pressures. And so the groups do recommend to limit the plateau pressures. Able. And here's just a chart, showing all the pediatric studies looking at tidal volume, and they all have different findings, whether there is an association or there isn't. PEEP. So again, they're adult meta-analyses showing that there has been a mortality benefit with higher PEEP. And in PEDS, we have this one study here that's actually comparing what we do for PEEP in the PICU versus what the ARDSNet protocol would recommend. And these are the ARDSNet protocol combination tables where you basically titrate the PEEP based on FiO2. And this study was looking at whether we are titrating based on this protocol or not. And they found that we are actually giving lower PEEP than recommended, and that the mortality has been increased with this. And obviously, the study isn't able to totally prove the correlation, but they did adjust for other markers and still found the same results. So this chart is looking at the PEEP for the FiO2, and these are showing those levels in the studies that they looked at. And this green line is what the ARSNet protocol actually recommended. So what we're seeing is when the FiO2 was less than 40%, we were actually using higher than recommended PEEP. And then once we got above 50, we were using much lower than they were recommending, and the mortality was higher. And this is now actually looking at the specific mortality. So they had created this discordance score that was what the ARSNet protocol would recommend minus what we were actually giving. And they split them into the severity groups, and they based it on the PaO2 to FiO2 ratio. So A is all patients, B was 200 to 300, and the lower number is severity. C was 100 to 200, and D was less than 100. And what they found was that the patients had the lowest mortality if the discordance score was 1 to 4. So we were not using as much PEEP as would be recommended. So when we do use, so I was just telling you about how we do use less PEEP than we need, but too much PEEP can also be bad. Like I had showed you in the graphs before, when you get to a certain point, you can overdistend the alveoli, and over time that can cause injury. And so this is ventilator-induced lung injury. And so we have different types. There's barotrauma, which is from too much pressure, volutrauma, which is too much volume. Atelect trauma is when you have the shear forces of the constant opening and closing of the alveoli. It'd be better if they're just staying open. And biotrauma is from an inflammatory response to actual mechanical ventilation. So again, there are studies looking at the differences between ventilator-induced lung injury between adults and children. And there are studies here, it's mostly in animal studies, looking at newborn rats versus adult rats. And what a lot of the studies found is that the adults were more likely to get ventilator-induced lung injury than the newborns. And some thoughts behind why this was happening was because the children had, or the baby rats had, less of an inflammatory response. It could also be because of the different properties in the lungs, such as like the elastin and the collagen. They also found that when the surfactant was affected, there are different types, the large aggregates and the small aggregates. And the large aggregates are more functional, and the small just aren't at all. In the adult lungs, it's being converted more to small aggregates. So you can see here, this side is pediatric, this side is adult. Here are the surfactant aggregates, and you see the more small. You're also seeing more inflammatory markers in the adults than the pediatrics. And then there's different types of the hyaline membrane. It's more elastic here and more collagen here. And this isn't to say, though, that pediatric patients don't get ventilator-induced lung injury, because there are studies specifically looking at that, and that does happen. So we do have to be careful with what we do on the ventilator. So I told you that PEEP is good, we need more, but too much PEEP is also bad. So how do we know what's the right PEEP? Every patient is different, so there isn't a standard PEEP that we can necessarily use for everyone, depending on the severity of the lung disease. Some patients' compliance is much worse, so you may need more PEEP, you may need more pressure. So some ways to kind of figure out what this optimal PEEP is we can look at the PaO2 or the SpO2, and rather than increasing FiO2, increase the PEEP. It's like we talked about before with PEEP, it can increase our oxygenation. And in ARDS, increasing the FiO2 may not always help as much because of the shunting, and shunting isn't affected by the FiO2. We can also trend our oxygenation index or the oxygen saturation index. And if that's getting worse, we could try to come up on the PEEP and see if that improves compliance. So the compliance will show up on the ventilator. And so if you keep your same volume, but increase your PEEP and you see that the compliance goes up, you could be aerating more lung units, opening more up and getting more oxygenation. But if you see that the compliance goes down as you increase the PEEP, you could actually be over distending and reducing the oxygenation. Some studies have looking at esophageal pressure as kind of a correlate to pleural pressure to see if that's how you can titrate PEEP. And then one other way to actually see and visualize if you're recruiting lung or aerating the lung is imaging. And there are some older studies looking at CT, but we could also do lung ultrasound. So a little history about lung ultrasound. It wasn't always used as ultrasound was. Radiologists thought that it wouldn't really be helpful because of the air. You can't really see anything. But then in 1980, this guy started looking at ultrasound using in horses and found that there were all these artifacts that he could see on the ultrasound that actually was correlating with underlying pathology. So then it started to be used more. And in the beginning, we had these huge ultrasounds that were the size of refrigerators. And then as the years is definitely changed to the point where now we can use ultrasound with our cell phones. So some things about lung ultrasound specifically, it's non-invasive, there's no radiation, can be fast, you can do it right at the bedside. It can help differentiate your cause of acute respiratory failure in a patient if you have a lot on your differential. You can often see pathology on ultrasound before you would on a chest x-ray. But one barrier to routine use of lung ultrasound is training. So to take a step back and just talk a little bit about the basics of ultrasound in general, we have this probe and it sends sound waves to an object or a difference between fluid and a soft tissue. And that will then reflect waves back to and here it's just showing where we're using the ultrasound and what we're looking at and what parts of the lungs we can see. So to talk about what we actually see on lung ultrasound. So lung sliding and A-lines. Lung sliding correlates with the intact parietal and visceral pleura. And you'll actually see it kind of slide. And I'll show you some videos in a minute. And A-lines are horizontal hyperechoic lines. And these are basically created by reverberation artifacts from reflection of the ultrasound waves between the pleural line and the transducer. If you have lung sliding and A-lines, then that tells you that you have normal aeration. So here, this video, here's the pleural line, this bright line here, and you can kind of see it slide across the screen at the top. And then down here, you see kind of parallel straight lines going across, and these are your A lines. And so this is normal aeration in a patient. B lines are hyperechoic vertical lines that extend down from the pleura. And these represent their interlobular septa when they're widening from hydrostatic or inflammatory fluid infiltration. If you have 2 or less, it can be normal. But if you have 3 or more in a single rib interspace, it's pathologic. If it's just in one part of your lung, if it's focal, it would suggest more likely pneumonia. If it's more diffuse and you're seeing them everywhere, it's more likely a diffuse alveolar process, which could still be pneumonia, but could also be like pulmonary edema or ARDS. So here's a video of B lines. And so again, you see that your pleural line up here, this bright white line. And as you see them breathing, you see these vertical lines shooting down. And those are the B lines. And notice how you're not seeing those horizontal A lines. And so that's also a feature of these B lines. It totally takes those away, showing that your aeration isn't necessarily normal anymore. So you can also see consolidation on lung ultrasound, and this is when the alveoli are filled with fluid or they're actually collapsed. So you have decreased acoustic impedance due to the lack of air beneath the pleural surface, and you can actually visualize the lung. And the echogenicity is similar to liver, so we call it the hepatization because it will look like liver. So before I play the video, down here is your liver. This dot showing you up, your head's up here. So here's your liver. This bright line here is your diaphragm, and this is actually the lung. And so you can see as taking a breath, your diaphragm's moving and the lungs moving. And there's some black in between the lung and the diaphragm, that's fluid. But this is all consolidated lung there. So it looks much different than the aerated lung where we're seeing straight A lines. And this is just showing kind of the spectrum of air to fluid. So here, again, your pleural line, you're seeing your A lines, horizontal lines, so that's normal. And then as you get less air and more potentially fluid, these are B lines. So here's your pleural line. And again, these straight lines going down your B lines. You're not seeing the A lines. And then C is consolidation. So just like that last video we saw, our liver's down here, diaphragm, and then this is the lung, which looks like a liver. And then this last one, here is the liver, the diaphragm, and you're seeing all black here. And this is all fluid. And this is actually your lung here. So there's a big pleural effusion there. So there have been studies looking at the evidence behind lung ultrasound. This one particular study compared ultrasound to chest x-ray and found that for interstitial syndrome, the sensitivity on lung ultrasound is 94% versus 46% on chest x-ray. Consolidation can be it's the sensitivity is 100% on ultrasound versus 38%. Pleural effusion is also 100% versus 65%. Pneumothorax is 88% versus 52%. And then again, you can often see large basilar consolidations on ultrasound that you will see nothing on chest x-ray. So it can give you a little more information sooner. And then, like I had mentioned before, there had been earlier studies looking at CT to assess the lung aeration. In this study, it's an adult study, it was comparing CT to lung ultrasound. And so they basically had patients and randomized them one to ultrasound or the CT, and they created this lung ultrasound score and compared it to the areas on the CT. And they did find that this lung ultrasound score correlated with the areas on the CT, indicating that lung ultrasound could also accurately tell us the lung aeration that we were seeing on CT and acute respiratory distress syndrome patients. So to bring it all together, to talk about the lung inflation, the mechanics, ARDS, and lung ultrasound, we have a study in the PICU. It's the Bedside Thoracic Ultrasound Guided Assessment of Lung Inflation in Pediatric Acute Respiratory Distress Syndrome. What we were really looking at was to see if we could see improvements in lung aeration on ultrasound as we increased our PEEP on the ventilator. And we also were hoping to see that this optimal PEEP that I talked about earlier that we were finding by the oxygen saturation index and the compliance would correlate with improvements in aeration that we were seeing on ultrasound. And I won't go too in depth in our actual protocol, but basically what we did was we had a patient with acute respiratory distress syndrome, and we would make changes in their PEEP on the ventilator, keep them there at a certain time, and do a lung ultrasound at each level. And then we would look at the ultrasounds at each level and give a score. And then the score, we looked at 12 specific locations on the patient and added that score up and then kind of correlated that with the oxygen saturation index and the compliance. So here's the actual score that we used, the global ultrasound score. So 0 is consolidation. 1 is severe loss of aeration. So you have multiple B lines that are pretty much kind of close together. You can't really define spacing. 2 is moderate loss of aeration. So you can see B lines, but there's well-defined area between them. And then 3 is normal aeration. So you're seeing the A lines. And so the higher the score, the better. So we started this study before the time of COVID and had a couple patients, but since then we haven't had any, but we'll look at one patient, a 10-year-old who had ARDS, likely secondary to pneumonia. You can see his chest x-ray here. Obviously see this pneumonia. And so here are some ultrasound images. So this was at the right upper anterior part of his chest. And when we were at the highest PEEP, 14, this is what we were seeing. So you have the pleural line and you're seeing A lines. So you had normal aeration at the highest PEEP. As we came down on the PEEP though, at this same location, we then saw this. So pleural line, and then you're seeing these straight lines going down. So now we're seeing B lines at that same location. So as the PEEP went down, we were losing aeration. And at another location on the left side, again, started out like this, where you have your A lines. That was at 14 a PEEP. And then we came down on the PEEP, pleural line, and you're seeing some B lines. And then when we went down even further, we start seeing this. And so this is your pleural line here. And under here, what you're actually seeing is consolidation. So you're not seeing A lines, you're not seeing B lines, we're not seeing really any aeration at all. So as we came down on the PEEP, we totally lost aeration and had collapse. And here are the specific numbers for our oxygen saturation index, our compliance, and our lung score as we went down in PEEP. So we went as high as 14 and went as low as 6. So for our oxygen saturation index, the lower number is actually the better number. And so it was actually best at the lowest PEEP. And the compliance is better, the higher number, and that was best at 8. And then the lung score was best at a PEEP of 14, so the highest PEEP that we did. So here are some graphs specifically looking at this data. And so this is the graph of the lung score. And so you can see as the PEEP is increased, the lung score increased. And here is a chart looking at the compliance. And as we increase the PEEP, it increases initially, but then starts coming down as we increase the PEEP. And then here is our oxygen saturation index. And again, the lower number is better. And as we increase the PEEP, it actually increased. So this study does show, like we thought, that the aeration would improve as we increase the PEEP. The lung score did get higher, but the optimal PEEP from our ultrasound findings didn't correlate with the optimal PEEP from the compliance or the oxygen saturation index. And I think what this shows is that as we were getting some improvements initially as we increased PEEP, and then it was starting to worsen. And what that may indicate is that we were actually over distending. And so as we over distend, we're reducing the compliance and thereby reducing the oxygen, which will affect the oxygen saturation index. So our ultrasound can show improvements in aeration, but it doesn't necessarily show us when we're actually over distending. So we can use the ultrasound to prove which lung segments are aerated or not and can actually be recruited. And we can find at that last point where it starts, where it goes back to losing aeration. And then another important part that we found with this is the significance of the lung heterogeneity. So I had showed you those two spots on the right and the left where the aeration got worse as we went down on the PEEP, but there were other spots in the lung that either totally stayed the same despite the PEEP, and there were actually some spots that the aeration got better as we decreased the PEEP. And so it truly is different in all parts of the lung, which is really makes this disease process hard to manage, because we want to protect those parts of the lungs, but we also need to give adequate pressure. So the big takeaway points from this talk is that many of our patients can be at risk for acute respiratory distress syndrome. It's not just patients who have pneumonia, it can be from sepsis, it can be from pancreatitis. And again, the lung disease is heterogeneous. ARDS is a problem of oxygenation. PEEP is good, but too much is bad. We need more data in pediatrics. And lung ultrasound can be useful, easy, and quick. My references. Thank you to everyone for listening. Thank you to my program and all my residents. Any questions?
I just wanted to thank you, Ariel, for a wonderful presentation. I think particularly the ultrasound work that's happening here is really exciting. And I just wonder, how widely spread is use of ultrasound, particularly at the bedside here in diagnosing lung pathology, as it seems like we overwhelmingly rely on chest x-rays.
Yeah, in the PICU, I think we're starting to use it a lot more. But again, most of the time we're still getting chest x-rays. But it is kind of helpful to compare what we find on the ultrasound to the chest x-rays, because sometimes we're not seeing anything on the chest x-ray. But then you put the probe on the chest and you're actually seeing B lines everywhere. And so it can give you more information. And so I think some of us are starting to really try to use it more. Part of the issue too is that we don't all have training in it. And so it can be hard when you first start doing it, but the more you do it, it can be easy. And then I see a question in the chat. When using an ultrasound on the lung, are there specific intercostal spaces that should be utilized to get the best visual results? So when I do it, I try to look at all different intercostal spaces, anterior, lateral, posterior. If it depends on what you're actually looking for. If you're looking for an effusion, it's best you can kind of get the best view down by the liver, so that you can see the diaphragm and the liver below it, and then see the fluid and the lung moving above it.
And I can read you the questions. Dr. Olshan says that he's aware of situations where using a chest x-ray have likely misdiagnosed a cardiac issue when in fact, I'm not quite sure, when in fact it was more likely cardiogenic edema. It seems like ultrasound may help in this regard. So I guess I'm saying cardiogenic.
Yeah, so ultrasound can be really helpful too, because you can also look at the heart. So you can see that there are B lines, but then you can also use the information with your ultrasound, seeing your heart function. And obviously we're not all cardiologists, but there are quick and easy ways to see if the lung, the cardiac function is reduced. And then you can also look at like your IVC as well to see if it's collapsible, and kind of put all of that information together that you wouldn't necessarily get from just a chest x-ray.
And then another question from Jesse Schaumburg is, when you did your study, did you find you needed 14 of PEEP to show A lines and good lung recruitment? again, or was it often found at lower values of PEEP?
It was often found at lower values of PEEP. You didn't just need the 14 to see that. And, if we went down, where we're at like 6 and we totally lost aeration, but if we went back up to like 8 where there was good aeration, it would be there again.
And I'm not sure if Dr. Zubrow is able to be on this this grand rounds, but I know like he is a pioneer in this work, and wondering if what you would suggest or what he would suggest in terms of trying to roll out training for residents and potentially hospitalists, pulmonologists, cardiologists, others for ultrasound.
I don't know if he's here, but I do know that he is working on a project to try to use like a virtual way of teaching people how to use ultrasound, and rather than just him or one person doing it, so that more widespread people can learn how to do it.
And Heather Daigle asks, do you envision that ultrasound will be a tool that is primarily used by physicians at the bedside, or do you think ultrasound techs will become more involved as this type of assessment? As in, do you think we will be able to one day order a formal stat lung ultrasound the same way we order a stat chest x-ray if we're not trained in doing this ourselves?
You can order a formal ultrasound now, and the techs will come up and do it, and have a radiologist do it. It just takes, whereas, if you have a patient that's acutely sick and you can just do it yourself at the bedside, it could be more beneficial.
And so I think Mike is on the webinar. I don't know, Elizabeth, if you can elevate him to be a panelist. There's another question about whether ultrasound is being incorporated into the pediatric residency training program.
No. It is incorporated in our medicine training program. We have ultrasound electives, and we actually have butterfly ultrasound available to. We can use our inpatient room.
So Mike, do you want to comment?
Yeah, sure. So I think that the biggest piece of training is that there are kind of multiple levels to it. I think there's the kind of cognitive piece that is required to kind of understand the kind of basic physics of ultrasound, which you can get in doing one of these kind of short form courses that take place over the course of a weekend. And then there's the kind of two other pieces, the kind of image acquisition piece and the kind of interpretation of images piece. And I think those two things are probably the hardest thing to kind of get going at a place like this, where there are very few people that kind of have formal training and formal credentialing in ultrasound. So we have a bunch of studies ongoing right now as to kind of the best way to get around that, especially in the setting of COVID, where there's kind of so much value in not having to expose a chest x-ray tech and wait 45 minutes for an x-ray to get into a room to kind of try and diagnose COVID lung disease. I mean, there's so much data out there that to say that COVID lung disease can be very easily diagnosed with ultrasound. But to go back to my point about kind of the training pieces, I think, like I said, the hardest piece is just having people to do it. So what we're looking at is whether, as Ariel was alluding to, whether this can be done virtually in some way, whether you can have the trainers be remote and have the folks who are learning kind of go through the standard weekend course and then have people remotely kind of help them consolidate their skills, or whether this has to be done in person, or whether there can be some kind of hybrid of the two. Because I think that's the biggest piece that's lacking right now, is not necessarily the availability of courses, but the consolidation of skills. To go back to Heather's question, I think it's a great question as to kind of how this enters the kind of common space where I think it's such a useful adjunctive physical exam tool that I think in the future, a lot of these are being rolled into medical school curriculums, and you're going to have a lot of people coming out of residency and fellowship with more training than the attendings, which is kind of a weird thing to think about, but I think is something that's probably going to happen over the next 5 to 10 years as people get more and more ultrasound training. So it'll be an interesting thing to kind of get the folks who are kind of now out and practicing trained up. And that'll be kind of an ongoing discussion, an ongoing question that probably remains to be answered. But I think it's an exciting time for ultrasound. Great presentation, Ariel.
Thanks.
And Dr. Sears says, certainly we use ultrasound every day in the adult ICU and on the pulmonary service. It's been very helpful during the COVID pandemic and hard, when it's really hard to listen wearing Pampers.
Yeah, and I think one of the interesting patients that we had recently where it was a question of kind of MIS-C versus active COVID, I think the ultrasound was really helpful in terms of kind of looking at, is this kind of primary cardiac disease, or does this look more like COVID lung disease? And in all honesty, it looked a lot more like COVID lung disease, which would be more consistent with kind of a primary COVID illness.
I don't see any other questions. So unless you'd like to make some summary closing comments, I wanted to thank Ariel for a wonderful presentation and for bringing to awareness the evolving utility of ultrasound, and Mike for really pioneering bringing this to the Barbara Bush Children's Hospital and hopefully pushing it forward with new and exciting technology. So thanks everyone for coming.
Thank you.